I can hit the record button and we can get started. Good afternoon, everyone. My name is Wendy Farthing. I'm with the Maryland Living Well Center of Excellence. I serve as the Director of Community Integration, and this is month 2 of our Ask the Expert, the Educational Lunch and Learn series. I'm with Jane Marks today from Johns Hopkins GWEP program and Dr. Jessica Colburn, and I'm going to turn this over to Jane for introductions.
Thank you, Wendy. Welcome, everyone. We're excited to bring our Ask the Expert series. This is our second one. And today we're talking about promoting brain health. And our speaker is Dr. Jessica Colburn. Dr. Colburn is an associate professor of medicine in the Division of Geriatric Medicine and Gerontology at Johns Hopkins University School of Medicine. She's also our director of the Johns Hopkins Geriatric Workforce Enhancement Program and the director of the Geriatric Medicine Fellowship Program at Johns Hopkins University. So we're excited to have her today. We're going to ask everyone to mute themselves. If you have a question, type it in chat, and we'll go through our presentation and questions that we have. And then I know some of you have sent in questions earlier, and we'll address some of those at the end and discuss some of our future plans. So welcome. Okay, so our first question, Dr. Colburn, if you want to change the slide, Wendy, is what's considered normal changes in memory as we age?
Thank you. Well, thank you for having me. I'm delighted to be here and to work with this great team at Johns Hopkins and at Mac. So thanks to all of you for joining us. So thinking about normal changes in memory as we age, next slide, please. So I think it's important first for us to think about different ways that we use memory in our day-to-day life, and that we think about executive function to talk about what's normal as we age. So just to talk through a few different types. So working memory is the kind of memory that is brief and is really used often to complete tasks that we do in our mind. So like to do a math problem when you're counting out change at the cash register, for instance. So something that you just kind of briefly store to recall memory in the moment to be able to do an actual task. Episodic memory is what we often think of when we use the word memory, which is our recall of past events or experiences that we lived through, were part of, that had in our own lives. And it can be things that are concrete, like what we did yesterday, or it can be kind of moments that were from the past further away. Semantic memory is kind of general knowledge, facts, the part of our brain that says, oh, that's an apple, like things that we learn over the course of our life. And then executive function is not really memory, but is the way that we organize and kind of regulate our day-to-day. So thinking about both planning, so tasks like planning a trip, organizing your medications, driving a car. These are things that kind of need some level of executive function. And also in regulation, we think about emotion regulation is also part of executive function, conflict resolution, how we manage impulses, all of those kinds of things all fit under executive function. And I'm going to talk through in the next few slides some more specific examples, and then I'll talk about how this relates to what we experience in normal patterns of aging. So next slide. So these are a few examples of working memory. So like I said, things that you do in the moment. So if folks remember that song 8675309, right? So when someone gives you a phone number and you remember it, or you look at a phone number on a piece of paper and you go to a different screen and try to dial it. So remembering that number, remembering direction. So that's a map of a neighborhood. If someone says, take the second left, and then at the light, take a right, and then at the stop sign, it's right there on your left. If you remember those short steps, those things, and then the math problem I mentioned before, those are working memory. Next slide. So episodic memory are things like, what did you have for breakfast? A vacation that you might have been on in the past, a family wedding or event that someone attended, and these might be longer or short term. in dementia and cognitive impairment, people lose short-term memory before long-term memory. In normal aging, short-term can sometimes be harder to recall than long-term also. But this is what we mean by episodic. And sometimes people will answer episodic memory questions with semantic memory questions if they're developing cognitive impairment. So if I say to one of my patients with dementia, "What did you have for breakfast?" and they say bacon and eggs, but that's not what they had for breakfast, they might just be remembering that that's a thing someone might eat for breakfast, right? So episodic memory is being able to remember your own experience of what you had for breakfast today. Next slide. Whereas semantic memory is more knowledge. So that's the part where what are breakfast foods is semantic memory. And as we'll talk about in a few slides, in people hold on to semantic memory longer than episodic memory, which is why my patients might not, with dementia, might not be able to tell me what they had for breakfast, but can tell me what a person might have for breakfast when I ask them about that. So semantic memory is knowledge. So someone who might have been a watercolor painter, or how you change a tire on a car, tasks you learned how to do. Scrabble, things like playing a game or remembering words, and language and communication. Books that people read, if someone's had an interest in history or marine animals or something like that. So the general knowledge is in the category of semantic memory. Okay, great. Next slide. So now that I covered some of those things, just to remember, so what do we see with normal aging? So working memory, that phone number or math calculation, and how fast someone does a math problem or processes something new, those are things that start to decline in early adulthood. So remember, when we think about aging, we are all aging all the time. This is a lifespan of aging. So aging isn't only something that happens to older adults. So working memory starts to change even in early adulthood. Episodic memory, so vacation, family events, what I had for a meal, that declines a little bit with normal aging and more commonly after the age of 60. So sometimes people can't grasp the exact details. They forgot, was it last week or a few weeks ago that we did that event maybe, or someone says, "Oh wow, that thing we did was really 5 years ago." So that those kinds of changes are normal with aging. And some pieces of executive function, planning, organizing, in particular multitasking, which humans aren't as good at in general as we think we are, but certainly as we age, doing multiple things at the same time can become a little more challenging. Next slide. So here's the good news. What improves or remains stable with normal aging? So one, if there's some Wordle fans in the crowd here, verbal abilities, vocabulary, and word knowledge are often well preserved with normal aging. So this isn't cognitive impairment or dementia, that people really retain that and continue to learn it. Semantic memory is stable or actually improved. So that's knowledge, right? People in their 60s, 70s, 80s, 90s are still learning new things, even with normal aging. So this is knowledge accumulated over a lifetime. And some components of executive function may actually get better. So older adults often are better at conflict resolution after having a lifetime of experience working on problem solving and conflict resolution. Older adults are often also better at emotional regulation. Again, not all, this isn't everyone, but the experience of focus and attention and managing one's emotions over life, if that's a skill that someone has worked on, something that actually can improve or at least remain stable with normal aging. Next. So important just to make a note, what is not normal aging? So changes in memory, any of the types of memory, or executive function that impact somebody's ability to function and carry out their daily activities of daily living is not normal aging. So those changes I mentioned are the kind of thing that's like, I can't grasp where exactly in the house I left my keys. That's episodic memory, right? I put them down yesterday and now I can't remember where they are. But trouble managing or remembering medicines, not just like, oh, did I take it yesterday or today, but just managing the task of medicines. Driving, someone's having trouble driving, getting lost, getting in more accidents, those kinds of things. Those are trouble with daily living. And the third picture is because sometimes what people will say to me is like, you know, my mom has cooked this family recipe for years. She never uses the cookbook and she can't remember how to do it anymore. That's semantic memory, right? So someone who used to be able to cook. So things that are impacting your daily living are more concerning and would not be in the category we'd consider normal aging. Next. And then the last part I just want to call a word to is a word about ageism. So often there are jokes and comments made that say things like, oh, I'm having a senior moment, or I'm losing my marbles, or those kinds of things. And I think it's important to remember the things that are stable or actually better with aging so that we try to kind of practice removing some of this language that suggests that all older adults lose their memory, when that is not true. And in fact, many older adults have certain things that are better as they age. So trying to catch ourselves when we're saying these things and trying to get some of the ageist language out of our daily use, I think is important. All right, enough about that. Thanks. Next slide.
So, Dr. Colburn, what actions can we take to promote positive brain health, including things like nutrition, activity, social engagement, brain games, all the things that come to mind about what we should be doing?
I love these questions, Jane. Thank you. Next slide, please. So let's talk first about nutrition and the brain and what we understand about ways that you can help protect your cognitive function with nutrition. So next. So the studies that have been done have shown that the best diets, the best approaches to nutrition with cognition as the goal are the Mediterranean diet and what we call the DASH diet, or dietary approaches to stop hypertension. And you could Google either of these to see things that the foods that fit each of those diets. But the things that are most important or central to each of them is that they are largely plant-based. So vegetables, whole grains, nuts, legumes, lentils, things like that. So largely plant-based. That the fats that are added are typically healthy fats, so things like olive oil, and that they often include lean protein, so chicken, fish, vegetable protein, things like that are part of it. It's typically low salt also. And so these have been shown to improve cognitive function, so people who kind of adhere to this diet over time, and decrease the risk of dementia. And on the next slide, this slide actually is from a study, and that's small, but I'm going to talk you through what you're looking at. The left side is the Mediterranean diet. The right side is the DASH diet on those squares. And what they're showing you is for people, the blue line, which is the top line, is all of these lines are cognitive function over time, over several years. The blue line is people who adhere more regularly to that diet. So again, we're not looking for perfection, but people who are more likely most of the time to be adhering to the Mediterranean or DASH diet had the highest levels of maintenance of their cognitive function. So those cognitive scores were the highest in the blue group, which is the people who followed the Mediterranean diet the most closely. The green line is in the middle, and the red line in the bottom is the people who were the lowest adherers to the diet. So whose eating approach was the most removed from Mediterranean or DASH diet. And those folks, you can see over time that their cognition declined a little bit more. So this is one of the studies lending evidence to the fact that for nutrition, plant-based, healthy fat, lean protein is the best way for us to be leaning with our food, low salt. Great. Next slide. So exercise, now also important for cognition. I love this slide of the brain lifting weights. Next. So physical activity. So observational studies, and I'll tell you what you're looking at in these graphs, have shown that higher physical activity is associated with lower risk of cognitive decline. So 0.6, meaning 40% less risk of cognitive decline, and lower risk also of dementia. So about a 14% less risk of dementia for someone who is exercising. And what it shows here in the graphs is each one of those lines is a different research study. So this was a study that looked at a whole bunch of studies that had been done looking at physical activity. On the left for cognitive decline, so whether someone's cognition gets a little bit worse over time, and on the right is an actual diagnosis of dementia. And you can see the line, the vertical line that goes up and down in the middle, that black line there, yes, thank you, is kind of where the study is not significant. So if it crosses that line, it wasn't significant. So everything on the left is showing us that all those horizontal lines that are to the left of that line mean that you, the more physical activity you did, the less chance you would have cognitive decline. And the same on the right. The more physical activity did, the least likely you were to have dementia. So this is basically just showing that in all of those long list of studies, there's maybe 15 horizontal lines there. For every one of them, people were less likely to have cognitive decline or dementia if they were doing more physical activity. Next slide. And in particular, this study these couple studies were very impressive to me. So thinking about physical activity to preserve cognition. So the types of exercise we want to be thinking about are either aerobic exercise. So that's the kind that raises your heart rate. So walking, swimming, biking, dance class, things that raise your heart rate, that make you sweat a little bit. Those are aerobic exercises. And MCE stands for multi-component exercise, which means that there might be some aerobic, but it also often includes some resistance or strength training. So meaning even like 1 pound weights that somebody is lifting, some yoga, some stretching, something that specifically strengthens certain muscles, Tai Chi, things like that. So aerobic, the kind that raises your heart rate, multi-component, the kind that does other types of exercise. So in these studies, they showed if someone did not have dementia, so if they were in the group that did not have dementia, people who did either aerobic exercise or the multi-component exercise were less likely to have a new diagnosis of dementia in 6 years. If you had mild cognitive impairment at the time that these studies began, and you did aerobic or multi-component exercise for about an hour twice a week, they showed overall an improvement in someone's cognition as well as their executive functions. That's the organization and planning. And in the group where people had a diagnosis of dementia, I mean, they already had dementia, if they did aerobic or multi-component exercise, they actually were able to improve their MoCA, which is a cognitive test that we do out of 30 points, by about 7 points. And that is actually quite impressive. If you think the medications that we have available for dementia improve the MoCA by about 2 points, some of them even 1.5 points. So the fact that, again, this was one study, but the fact that exercise, twice a week or 3 times a week could show that much improvement in cognition is really something that you can do or be encouraging your family members to do to really help protect their brain health. Next. The next is social engagement and connection. So also important. Next slide. Studies have shown that people who are more engaged socially, so who attend groups, who go out to lunch with friends, who are in a book club, who volunteer, so people who see other humans, are engaged with other humans, and who have that contact frequently have a lower risk of developing dementia and cognitive impairment. Now, interestingly, in these studies, support alone did not decrease the risk. So knowing someone you could call for help, for instance, wasn't necessarily enough to improve cognition. So there is something about that actual interaction with other humans that helps to protect cognition. And then also it's important to note that loneliness is associated with an increased risk of dementia. So the social engagement and social contact seem to be really important in the sense of connection. And we saw a lot of this during the pandemic when people were really isolated from each other, that in many situations, people told us that their family members' cognition would sometimes worsen during this period of time when people were more isolated. So we kind of saw that more commonly. Next. And then brain games. So people ask us, do things like Sudoku help me protect my brain health? So this shows Mahjong at the bottom, crossword puzzles, and the top right is a game called Go, which also has to do with kind of how you lay out the tiles. Next. So studies have shown actually that there's an association between in helping to preserve brain health from the brain game. So meaning in particular games like Sudoku or Scrabble or crossword puzzles, kind of number puzzles, can help to improve episodic memory, spatial working memory, and grammatical reasoning. And that board games, in particular ones like chess or mahjong or Go, that one I mentioned, ones where people have to think about strategy, do seem to, in some small studies, also have improved cognitive function. So again, these won't prevent dementia. They're not a cure for dementia, but it does seem that social engagement, exercise, food, and brain games, all of these are things that can help to preserve mental connections and potentially at least decrease risk or decrease the rate of progression. Next. Great.
Thank you, Dr. Colburn. So our next question is, are there substances we should be aware of that can impact brain health, such as smoking, alcohol consumption, or use of cannabis?
Yes, absolutely. So we should be mindful of all of those. So first, thinking about tobacco use. So smoking actually has a strong association with increased risk of developing dementia. In fact, 1.5 to 2 times the risk of developing dementia in folks who have been smokers. And so smoking cessation actually is a really important way to decrease the risk of developing dementia. You can start to lower the risk even from quitting. So it's not even that, well, I've already been a smoker, so my risk is up. Well, that's true, but quitting can still lower someone's risk from now. So that's a really important consideration in thinking about cognition. Next. Alcohol also. So interestingly, there is an increased risk of dementia with alcohol intake that's at an average of 2 drinks a day or more. So for most people, that is more alcohol than most people drink, but many people have enjoyed 1 to 2 glasses of wine or scotch or cocktail in the evenings. And so being mindful that 2 drinks or more on average per day can certainly increase the risk of dementia. There is value to limiting alcohol use. Generally, the recommendation would be less than 1 drink a day for women or 2 drinks a day for men. There previously were studies that suggested that moderate consumption, so people probably had heard in the past that 1 glass of red wine a day, for instance, could actually be good for your health. But more recent studies have suggested that that's likely not true. And this is a place where probably we would describe this as a confounder, meaning that there are that people who are healthier might also be the same people who have the 1 glass of red wine a day. And so it's hard to know which direction the issue goes. Is it that people who drank 1 glass of red wine a day were more likely to be healthy, or people who were healthy were more likely to drink a glass of red wine a day? And what we're learning is that when we look at populations of folks who drink alcohol compared to folks who do not drink alcohol, that alcohol is a health risk, but definitely more alcohol in terms of cognition, so more than 2 drinks a day, is really where we're seeing the association with an increased risk of dementia. Next. And then cannabis also has to do more with long-term use. So people who use marijuana or smoked marijuana over a number of years actually has been associated with smaller brain volumes and some cognitive deficits in midlife, which can then predispose someone to developing dementia later in life. So these are about effects on the brain in young and mid-adulthood that can then impact us in later adulthood. And certainly active cannabis use can affect someone's cognition, which can improve from stopping cannabis. So again, this is kind of more something that might have happened in the past and affect the future, or for young adults or people in middle age. But daily cannabis use can certainly impact cognition from a day-to-day standpoint. Next.
Thank you, Dr. Colburn. One of our other questions that have come up is that what about supplements for memory? We see so much advertised in TV and magazines. Do they really make a difference in our memory?
Yeah, this is a really important question that I get asked quite regularly. So when we think about supplements, what we're talking about is vitamins or other types of supplements that are not prescribed medications by a doctor, but that someone might purchase and take over the counter at a local pharmacy or online with the goal of improving their health. And this can be a place in particular where it's really murky to figure out how helpful they are. So some big picture things first. One of the reasons why it can be challenging is that these medications, these supplements, are not well studied. So often we don't have the same kind of research and data that we have behind prescription medications that help us know when the medications are helpful and when they are not. And the other thing is because supplements, especially natural supplements, are considered food by the FDA, the Food and Drug Administration, they are not tightly regulated, which means even when we have studies, we don't always know, was the pill or tablet that someone taking entirely B12, or did it have other B vitamins mixed in it? How much turmeric was in there versus other fillers, for instance. And so sometimes the studies are not able to be quite as precise as medication prescription studies, which also can make it hard for us to know how to interpret some of the data. Next slide. One of the supplements that there is good data around is vitamin B12, but it's important to note that this is in someone who's B12 deficient. So B12 is a blood test we can check, and in fact, is commonly checked in someone who is noticing changes in their memory. The other symptom that B12 deficiency can show up as is neuropathy. So people can get numbness and tingling in their feet or trouble with their balance if their B12 level is low. Low vitamin B12 levels are associated with cognitive change. So if someone is telling us they're noticing memory changes or having these symptoms of neuropathy, we often check a blood level for B12. And if it turns out their level is low, then giving someone B12 to take and boosting that level up can improve their thinking and their memory. But it is not clear whether taking B12 when you don't have B12 deficiency adds anything. If your B12 level is normal, we don't have any data that really tells us if more is better in terms of a cognitive function standpoint. But getting the level checked and seeing if someone needs the level repleted and maintained over time is one important supplement to think about with memory. Next. Now, this is the one I get asked about the most frequently, Prevagen. So Prevagen is a dietary supplement. So it's actually not natural, it's manufactured, but it contains as part of it this apoicorin, which is a protein found in jellyfish, which is why the picture is there. Unfortunately, the studies of Prevagen have not demonstrated any benefit in terms of memory and cognition, even though the drug manufacturer says that it does. And one reason that it doesn't help is because this protein actually is entirely digested in the GI tract. So the protein that is supposed to have benefit for the brain actually never makes it out of the GI tract. And if it did, it's too large to cross the blood-brain barrier. So it doesn't have any effect on the brain anyway, but it doesn't even make its way out of the GI tract. And also, this supplement has been shown to have some side effects, which unfortunately, there actually have been some lawsuits because the company that makes it has not fully disclosed these side effects, including things like seizure, stroke, tremor, and confusion, which is the exact reason someone is taking the Prevagen to try to avoid that. And unfortunately, it also can be expensive, so $1 to $2 per pill. So next slide. This is a screenshot I took just yesterday from the Walmart online website where you could order Prevagen directly. And you can see here that this is more than $1. So on the left, regular strength Prevagen, which has 10 milligrams of that apoicorin. It has 10 milligrams of that. And it has some vitamin D in it. It has the two together. And the extra strength has 20 milligrams plus the vitamin D. But like I told you, because it's all unfortunately broken down in the GI tract, it doesn't matter if you take 10 or 20, it's just getting broken down in the GI tract. But it is more expensive to buy the extra strength version that's the double. So for $1 to $2 per pill, you'd be better off investing your money in your plant-based diet or in a social activity with a friend or in exercising, because there is more emphasis behind those than unfortunately behind these supplements. Next slide. And then I just wanted to cover some others. I found several studies that kind of looked at lots of other supplements, and as my teenagers would say, too long didn't read. The too long didn't read is that unfortunately none of these have strong benefit for dementia, but just to talk through them. So carnitine has over 50 trials, but unfortunately none of them have shown support for dementia. Coenzyme Q10, coffee or caffeine. I would love if coffee prevented dementia, but unfortunately there isn't any data that it does. Ginkgo biloba has had a number of trials and inconsistent and unclear evidence. Next. And then a few other supplements, omega-3 fatty acids. So again, some of these supplements may be good for other reasons. This is only answering the question of dementia and cognitive risk. So omega-3, B6, and vitamin E also were not shown to have significant improvement in cognition. Next slide. So in summary, thinking about supplements, dietary supplements are a multi-billion-dollar industry. And actually, I read just this week that supplements in particular for memory loss are a rapidly growing part of dietary supplements, because any condition that is scary that we don't want and we don't want for our loved ones and doesn't have strong treatments available yet has kind of an open market for other things that might help, that any of us would be eager to try for ourselves or a loved one. And so unfortunately, it's kind of an open market then for money to be invested in things that aren't as useful as we would hope. Most studies have not evaluated supplements in their raw form, like I mentioned, so it's not always consistent. And unfortunately, other than the B12, which I mentioned, there isn't significant evidence that the supplements we have available right now actually improve memory and cognition. Next. So I just wanted to share some take-home points, and then we can open up if there are other questions, maybe Jane, or if you have any others. So working in episodic memory, so again, that kind of quick calculation and remembering your own memories decline with normal aging. The semantic memory is typically stable and may actually improve. Conflict resolution, problem solving can improve with normal aging. This might be the part we think of as wisdom, right? People who have built semantic memory, life experience, and ability to help in guiding some of these things. Mediterranean and DASH diets are the ones that are best for your brain. Exercise is great, both the aerobic, the kind that raises your heart rate, makes you sweat a little bit, as well as some resistance training. Social engagement and frequent social contact is protective. Tobacco, alcohol, and cannabis at some level all increase risk, and supplements, unfortunately, are expensive and not as likely to help as some of the other things. Thank you. And then the next slide, I think, was next steps, but I'll open it up. Resources. Oh, right. Great. Thank you, Wendy, for including some of these resources that the Maryland Living Well Center of Excellence has available, including where you can find the recorded webinars for this series you're joining right now.
There's a variety of evidence-based programs that can connect folks to dementia classes as well as caregiving classes. We have a virtual hub that is available statewide for folks to participate for free in a variety of classes.
Thank you so much.
Thank you. Thank you, Dr. Colburn. Before we open up to questions, I'll just read the slide as Wendy has put up for our next month's Ask the Expert is Dr. Neiman, who is Associate Professor in Department of Otolaryngology, Head and Neck, talking about the impact of hearing loss on cognition. We hope you can join us. I don't have any questions in the chat box. Does anyone have any questions they'd like to ask? Unmute themselves. No? Well, there's been several questions written in. Just let me say that there's a lot written about Parkinson's disease. So we had a little chat earlier and decided that we're going to actually do an Ask the Expert. Have one of our physicians come and talk more specific about Parkinson's. We also have a session planned on non-Alzheimer's type dementias, which was another couple questions that was asked. There were some questions asked about how to reach out for help in your counties. And, I think in regards to if you have someone you're caring for with a diagnosis of dementia, certainly talking with your primary care team. They may have social work to help, but also the Alzheimer's Association. We have the Central Greater Maryland chapter in Towson, and then there's the Capital Region for Southern states in Maryland, as well as DC and Northern Virginia. And certainly, if you have questions about that, you can email me, jmarks@jhmi.edu, and I'll put my email in the chat so you have it. The other department that you may want to reach out to is your Department of Aging, because they often will have a caregiver coordinator that can help tie into resources for your area. So please feel free to reach out to them. And even if you're out of state, reaching into your family's area that you can then contact. There's also a website, Elder Care Locator, that can help with resources. That's good. And perhaps, Wendy, one of the things we can talk about doing is creating some of those links for people so that they do have that.
Yeah, that will be included in our, we've started that on our dementia webpage. So where this recording will be housed, I did put a link on that resource slide. We will add additional resources to that as well.
Yeah, I think that's great. There's a question too about the guide model that's coming out and whether or not that's going to impact people being at home. And I think that's part of what the guide study is going to include is to see what outcomes they can impact and resources. And perhaps that's a session too that we could include and invite some of our guide teams to come. So I think that would be helpful. Some of the other questions I think we can answer on our website so that you have resources. There's a couple that are just kind of confidential that went one-to-one, and we'll be glad to help answer those and reach back out to you.
There was a question in the chat that
Yeah.
I want to share. It is about pharmaceutical intervention for memory loss. If there is something that you can comment on and how effective they are, and is it true that they are only effective in the very early stages?
Yeah, that's a good question. So in terms of people who actually have memory loss, so we tried to frame today's questions mostly around kind of protecting brain health moving forward. But for someone who's been diagnosed with either mild cognitive impairment or with dementia, there are several medications available. They are very individual to the person, whether people want to try them or not. Unfortunately, for none of them is the data as strong as we would hope for. So there are several oral medications that are approved by the FDA. So donepezil or Aricept is one, memantine and galantamine are others. Memantine also is called Namenda. So those medications, donepezil is for early to moderate stage. Namenda is actually for moderate to later stages of dementia. And the FDA approval was that they may slow the progression. They do not, of course, cure dementia, but they may slow the progression and they may improve somebody's kind of behavioral manifestations of dementia, so mood changes or kind of agitation or some of those things. They all have side effects like every medication. So donepezil, for instance, its common side effects are some GI distress, some diarrhea or nausea, which we don't always want in someone who may have memory loss and is losing weight. And also it can slow the heart rate. So it's contraindicated for people who already have a low heart rate. And before we knew this well, I had 2 patients in the past actually get pacemakers, probably likely that were because of the donepezil. So I always counsel folks that they want to mention to their doctor if they're told that their family member has a low heart rate, that the memory medicine can sometimes do that. But sometimes we try those if folks are interested. The newer IV medications that you may have heard about, so lecanemab is a common one you may have read about in the newspaper. Those are approved for mild cognitive impairment or very early stage dementia. Someone has to be positive for the biomarker, like the genetic predisposition that would match the lecanemab medication. So these are only given by specific memory specialists who can test for these. They are by IV infusion, usually over 14 weeks. And unfortunately, they also require monitoring with PET scan and all of that. So, and generally they kind of improve, one of the colleagues of mine describes it as like if you had a grade C for your memory before, then after all of these infusions, you might have a grade C plus. So it doesn't even really improve things so dramatically for folks, and it is a lot to go through. And Julie, that's an important point. I see your point there that sometimes people say like, well, I'll just take a medicine if I get dementia. So preventing it isn't a priority. But unfortunately, none of our medications yet anyway work as well as we would hope. And so trying to reduce the risk and protect our brain health the best we can is a better way to go where we can anyway. And yes, Vonda, that's a good question. So we do sometimes use donepezil and memantine together. It kind of depends on the individual patient. Sometimes in the overlap in the moderate to advanced stages, people will take both, but sometimes it's only one or the other. It kind of depends for the individual person and their symptoms. So sometimes there's just one, sometimes just the other, and sometimes both.
Well, thank you, Dr. Colburn. If there's any other questions, feel free to certainly email us, and we'll try to take into account some of your comments in regards to planning our sessions too, so that we're addressing areas that you're concerned with. We are going to have a session coming up on medications and treatment, so they'll be discussed more in detail, I think, as well. Certainly, we would refer you to the Alzheimer's Association in regards to support groups for caregivers. There was a question that came in earlier about being stressed as a caregiver, and they can sometimes provide support as well as resources for you to help in caregiving. I think Wendy mentioned the programs that the Living Well Center offers, which caregivers have found very helpful, powerful tools in building better caregivers. So I would look on the website for those two as an added resource to help you in learning skills as a caregiver.
And those are free of charge, those programs.
As well as the Savvy and Advanced Savvy that are specific to dementia. They've been very powerful classes for our offerings, and we have several of them scheduled over the course of this year. We have started at least one caregiver workshop new per month on our virtual website. So I encourage you to look at the hub page for resources.
Yes, and someone did remind me of the 24-hour hotline from the Alzheimer's Association that, you can access someone to talk with. And I did put my email in the chat if we can help you with anything.
And one of the resources that is on that last page is a contact button for the Center of Excellence. If you are a physician practice or community-based organizations, or you need extra help or assistance, or interested in some of the program offerings, we will be responsive to that email contact there. So I want to thank everyone today for attending. This webinar is recorded. It will be loaded up on our hub page. A new invite for our March workshop Lunch and Learn will be going out with a new invite, and you'll be able to ask questions on that topic as well, and we'll try to incorporate that into the subject matter. So I appreciate your attendance today, and everybody make it a great day. Thank you.
Thank you all. It was excellent. Excellent.
Thank you.
webinar.
Thank
Thank you
you.
so much.
Thanks for coming.